I was really very impressed by Cochin Ophthalmic Club. I knew them for their academic excellence, but one thing which struck me most was the philanthropic initiative of giving back to the society, and that was something which I just couldn't move out from, and that still emphasizes the nature of our profession, and congratulations to Cochin Ophthalmic Club for that. Gopal, hats off. I really didn't know so much was going on. But I did have a small affiliation for Amrita because my husband did his PhD on proteomics as an external clinical candidate from Amrita. So, hats off to you and your team, and congratulations on this lovely, celebration of your award through your work done. So my talk was on biologics in uveitis, and I think this is another place where we are really moving ahead, and I thought I would like to share on certain experiences of mine when I started off and how we've moved on with this particular lecture. Now, as you all know, uveitis is a challenge for clinicians, and our primary aim is an immediate control of inflammation, and we do that with steroids. But we all also know that steroids is not the way to go forward, and we need something which is more sustained, and this is what is achieved by what we call as the DMARDs, or the disease-modifying anti-rheumatic drugs. And in this group, we have the conventional DMARDs and the biologics, and the biologics is what I'm going to talk about today. Now, this is a busy slide, and as a clinician, I would just get appalled when I see a slide like this, but what it is just trying to say is, when we talk about conventional DMARDs, we are looking at drugs which work on the intracellular pathways, and they have broader effects on the immune system. So if you are akin to warfare, I think that's a common topic which we now keep seeing. This is more like carpet bombing. You're trying to destroy everything around, and so that causes more of collateral damage. Whereas when we talk about biologics, it's more like a targeted bombing. So basically, this works on specific extracellular pathways. So it's something like a drone attack. So it just destroys only those areas. So the collateral damage is a lot more lesser. So if you have a disease where you know the pathway is very distinct, then the biologics is the preferred choice. So when we talk of biologics, they target different components of the inflammatory pathway, and the most common is the monoclonal antibodies against this pro-inflammatory cytokine, which is the TNF-alpha. Now, apart from this, we also have drugs which target on the interleukins, the T-cell, B-cell activation pathways, interferons, and more recently what we are seeing is the protein signaling pathways. And these drugs are usually made by recombinant technology, and depending on their source, the suffix is usually attached. Now, this is again a busy slide, and the ones highlighted in red are the ones which we commonly use in our practice. And these are the anti-TNF agents, the interleukin-6, the CD20s, and now the new steroid, as we may call, which is the Janus kinase inhibitors, which they have trying to take out this term from biologics, and they're using a term called targeted synthetic DMARDs. Now, compared to the rest where they work on a single cytokine, the protein signaling or the Janus kinase inhibitors usually work on multiple cytokines. So that's the reason now this is being preferred more in our practices. Now, just a quick look. Biologics, when it came, we couldn't still use it in our part of the world, mainly because of the costs of this drug. And this became a major limiting factor because in our patient population, most of our patients self-fund their own treatment, and this is when we started using, though we knew these were very powerful drugs, we could not use them because of the costs. So obviously, we are known for innovations. We started developing something which is analogous to the originator, and that is what we started calling biosimilars. Now, these are not the original drugs, but they're quite similar to how the original drug works. And this kind of reduced the cost significantly. And these are also large drugs, and they are prepared by recombinant technology. Now, to add this, we started also having generics in our practice. And these are chemically synthesized small molecules, and they are easier to take because most of them are oral, and this kind of really got down the costs. Now, just like how our, the other systemic inflammatory diseases, the use of these started going up, we started using this more and more in our practice of uveitis and scleritis as well. Now, this is, taken from one of our publications, and if you see, the most common drugs which we use, the biologics, are all biosimilars which we use, and generics. Of course, tofacitinib now has lost its patent, so we are getting the originator molecule itself. And if you can see, the costs are really down, and this has benefited many of our patients with non-infectious uveitis. So this was our initial paper, which actually was in 2023, where we had only 76 patients at that point of time who were on biologics. And if you look at the age range, we used it even up till 76 years. That was our oldest patient. And if you see, more than 75% of the patients were less than 45 years of age. So this is our economically productive age group, and this did make a big difference in this group. And we had a reasonably good follow-up of close to about 5 years when we published this paper. And these are the different indications. Mainly these inflammations were related to systemic diseases as well, and that's when we got out this paper. So whenever we want to start biologics, there's a lot of concerns. When do we consider? Which drug do we use? Who should start? Should I start? Should the pediatric or the rheumatologist start? What are the tests we need to do before starting? What should we look for? And how long do we need to continue? And the rest of my presentation will probably highlight these points. So I consider biologics in my practice when I'm dealing with refractory uveitis or scleritis which has failed conventional immunomodulation, and this could be either a single drug or a combination of conventional DMARDs, or there is a threat to the globe integrity, the vision, and even the patient's life. And we use biologics earlier if they develop adverse effects to the conventional DMARDs, and in diseases such as Behçet's and severe GIA, we've even started using them as a first-line therapy. Let me share a case. This is a HLA-B27 related uveitis, generally known to have an acute presentation, but this was one patient who had an acute on chronic presentation. And when we saw her, she had an endophthalmitis-like picture. That means she had a lot of vitritis, and this patient was already on steroids, combination DMARDs, but the systemic indicators were very high, the CRP was very high. So this point of time, we had to give her biologics, and she couldn't afford adalimumab, so tofacitinib was a drug of choice, and I've been seeing her for 2 years now with absolutely no recurrence, joint totally under control. Now, in GI-associated uveitis, just like my earlier talk, we did a study and looked at our patients, and we realized that those who had a poor visual outcome at presentation, who presents with BSK, occlusio pupillae like this, cataract, with cystoid changes in the macula, we've started using biologics as the first line itself. And sometimes you can see a granulomatous presentation in GIA uveitis, and this also shows chronicity, and it is better to start them on biologics at this instance itself. This is a patient with Behçet's who already had structural complications, optic atrophy, sclerosed vessels. You don't want to waste time starting conventional DMARDs, so this patient was started on adalimumab initially itself. So when we have a patient who is ready for biologics, which is the drug which you would choose? We have the FDA approval predominantly for monoclonal antibodies, which is anti-TNF alpha agents, and among this group, adalimumab is our first choice, mainly because of the ease with which we can give, because this is given by a subcutaneous route and it doesn't require hospitalization. And these are the different indications. But the important take home is avoid etanercept in patients with ocular inflammation because this exacerbates that. Now, these are the different interleukin inhibitors. In children with autoinflammatory diseases, which are refractory uveitis, we use IL-1 inhibitors. Unfortunately, these are very highly priced. We still don't have a biosimilar for this. And we do have used tocilizumab in patients with refractory macular edema, and we have had a few of our patients with Takayasu arthritis who had an extensive disease where tocilizumab was used. Secukinumab and IL-23 inhibitors, the data in uveitis is still ongoing, but I don't have much experience in with these drugs. B-cell inhibitors are usually used if I'm seeing a vasculitic component in the eye, either in the form of necrotizing scleritis, peripheral corneal infiltrates, in patients with orbital inflammatory disorders, in patients with OCP and multiple sclerosis, we generally prefer this drug. JAK inhibitors are now the new therapeutic armamentarium we have, and they basically target the JAK-STAT pathway, which is the protein signaling pathway. And tofacitinib is a drug which many of us are familiar with, and baricitinib and upadacitinib are being used more often nowadays, and they have worked very well with rheumatoid arthritis, ankylosing spondylitis, and we have one patient with Takayasu arthritis on upadacitinib. Again, these are drugs which are just starting to be used, so we still don't know how they're going to fare over a period of time. So based on our experience with tofacitinib, we just got these two articles, and definitely it has made a big difference because it has reduced the costs in many of our patients. But I'm sure many of us will agree that the results can be variable. One patient can respond to tofacitinib, the other patient may not respond to tofacitinib. So this is something which we need to keep in mind, and that kind of brings us to the next second generation of JAK kinase inhibitors, which are now starting to be used more often. I'll just share a few examples. This is a young boy who came to us who had failed adalimumab, infliximab, and had multiple intravitreal injections in the eye and had recurrent cystoid macular edema. And if you look at the FFA, there's a lot of fluorescein leakage, disc leakage, and CME. And at this point of time, we did give tocilizumab. And if you see the dramatic improvement in the vascular leakages, and he has been doing very well since, and we've been able to shift him back to azathioprine. Now this is a patient with ANCA-associated disease who had a posterior scleritis as well and had an orbital pseudotumor. Now the systemic disease was under control, but the eye was still active, and it was affecting his vision, and we did give rituximab in these cases. This is our series on multiple sclerosis associated uveitis, where the treatment of choice is rituximab, especially when they have a uveitis as well, and they did seem to do very well with these medications. So the next question which comes is, who should start? Should I start by myself? Should I include a rheumatologist? It is important to remember that these drugs target the immune system, and sometimes as an ophthalmologist, you may not have a clear idea of what is going on in the rest of the system. So ideally, we would prefer that these drugs are started with your rheumatology colleagues, either in your hospital, or if you're comfortable with rheumatologists outside and who can understand what is ocular inflammation. Ideally, we would prefer to start it in conjunction with them. And especially pediatric, I would always have a pediatric rheumatologist who would help me do the tapering and initiation. So what do we do before we start it? Mainly thing is we have to rule out infections, and the infections will be tuberculosis and viral. And we do get a hepatitis profile, ELISA for HIV, and routine screening for tuberculosis. It is always important to ask the patients if anybody in the family has suffered or is suffering from tuberculosis. And of course, we've had a few instances of demyelination as well. And this is something which you need to keep in mind, especially before you start anti-TNF-alpha inhibitors. We do ANA regularly in all patients with anti-TNF-alpha agents initiation. Mainly this can cause drug-induced lupus. And nowadays we are seeing quite a bit of dyslipidemia with tofacitinib, and as a result we do have a baseline screening of lipid profile before we start this drug. And if you're looking at rituximab, it's always better to look at the serum IgG levels in these patients. Now, India is an endemic country for tuberculosis. We have a lot of overcrowding, but if you look at our data, the amount of adverse events is low for a country which is highly endemic for infections. So anti-TNF agents, mainly you will need to look for reactivation of tuberculosis, drug-induced lupus, demyelinations, In Janus kinase inhibitors, viral infections are quite common. So generally, we do give chickenpox vaccine, flu vaccine before initiating the drug. We are seeing a lot of cases with dyslipidemia of late. And if the statins are increasing, I think it is important to keep that in mind and shift the drug. Infections and hypogammaglobulinemia are seen with CD20 blockers and neutropenia with IL-6 inhibitors. Just another minute and I will be finishing. This is a patient with Behçet's I had shown you earlier, and she needed anti-TNF and she started doing very well with that. The problem was actually on our side. We didn't ask her. She had a mother who had pulmonary TB, which she didn't disclose to us because she was getting the adalimumab free. And unfortunately, she developed disseminated TB, which also included intracranial involvement, and we had to stop anti-TNF agents. This is another patient with tofacitinib, and tofacitinib comes with a black box warning of you need to use this carefully in patients with occlusions. Now, this patient was actually a patient with angst, and she was taking adalimumab, and she could not continue adalimumab because of the cost. So the treating rheumatologist changed to the tofacitinib, which works very well. But unfortunately, after she started tofacitinib, she started having TIA-like symptoms, and she stopped the drug, and the TIA symptoms stopped. Now, she re-challenged herself with the drug once again, only to realize that the symptoms came back. And this is when we saw this kind of an impending vascular occlusion. And this can be seen in some patients with tofacitinib, and we need to be careful about that. This is a patient with lupus nephritis, and she was started on rituximab predominantly for her kidney condition. But what we were seeing in the eye was 2 weeks later, we started seeing this peripheral corneal infiltrate, which started kind of spreading. And this was actually very concerning for us. And sometimes B-cell inhibitors can be associated with paradoxical worsening after initiation. So sometimes you may need to give this drug with IV methylprednisolone. Sometimes these drugs work very well for some time, and then you see the drop. So this is one child with enthesis-related uveitis who failed adalimumab. She was on it for 2 years, and then we changed to infliximab. She was doing very well, and she was given it along with methotrexate. Things were doing fine, but then we stopped methotrexate because of her liver enzymes going up. And during this period, she had a surgery also done. She was aphakic. She was doing actually very well. But after 6 months, she started developing reactivations. Now, what do? This was a drug which was working very well earlier. So we did look at her anti-infliximab antibodies, which were negative. But what was interesting was the drug levels itself was very low. So this is when we had to increase the infliximab and also reduce the duration between the injections. So whenever you see a failure, ideally it is better to look out for antibodies. If you cannot, then you can just swap them to a different anti-TNF agent. And if it still doesn't work, then we kind of move to a different biologic together. But before we swap agents, it's always important to wait for at least 2 weeks before doing that. Now, the common question which is asked is, how long do I have to continue? Unfortunately, even we don't have an answer yet. But the American College of Rheumatology recommends at least 2 years of control of inflammation before attempting to stop. But there was this trial, which is the ADJUST trial, which came out, which looked at, they had an increased relapse of JIA-associated uveitis when they stopped the drug. So this makes us more believe that this drug has to be continued for a long time. And in our country, it's predominantly driven by the cost. So in practice, it is at least 1 year of therapy is what I tell them, and they should have at least 6 months of disease remission before I can adjust the spacing between the injections. Local injections are in trial. There are some case series on infliximab, adalimumab, and now the trial on anti-IL-6 monoclonal, which is showing a lot of promise. We just have to wait for the results and when it hits the market. So to summarize, we've come a long way from steroids, immunosuppressives, and biologics. And this is when I was a postgraduate, and we used to see cases like this. Then during our practice, conventional DMARD's problem was still there, and now with biologics, it looks like a normal eye. So ultimately, to conclude, it is always a smart battle between benefit versus the risk, and you should take into consideration socioeconomic status and the cost when we are planning these therapies in our patients. And in idiopathic cases, it is still a trial and error method. One may work, one may not work. I think we should still have our eyes and ears open and switch them appropriately. I thank you all for this.
Thank you, Dr. Kalpana, for that wonderful talk. I have one question. Madam, after 2 or 3 weeks of biologics treatment, when you feel that response is inadequate, how you, whether you add another immunosuppressants or biologics? Or?
So generally biologics when we start, we normally start with methotrexate. It's the most common combination and the most safer combination, adalimumab with methotrexate. And from my practice, at least with ocular inflammations, I need at least 6 injections for me to see the difference. So usually we wait for at least 3 to 6 months before we switch biologics. Tofacitinib, you can start seeing the need for you to reduce steroids much earlier. Probably a month is what we are looking at, but still I would wait for at least 3 to 6 months before I change drugs.
Totally change it or add another?
So we add adalimumab and methotrexate upfront. Yeah.
Ma'am, you showed a child failed adalimumab, so you shift to infliximab. So any reason for that? Or?
So basically this child was enthesis-related uveitis, and usually monoclonal antibodies work well in this particular group. So the patient did adalimumab, she was on it for 2 years, but we just couldn't take off the steroid, and she had already developed Cushingoid features, and she also had glaucoma because of the drops and the steroids which she was on. So that's when we shifted her to infliximab, and basically when she came to us, she came for another opinion, and that's when we shifted her to infliximab. So with infliximab, she did well. So that is the reason why we continued her, we could operate on her. But the problem was when we took out methotrexate. That is when the problem started. And again, this is one of the rarer forms. Probably she must be having an autoinflammatory component as well with her, because it was more of a refractory uveitis. And sometimes this group can have an autoinflammatory component which may not respond to the conventional anti-TNF alpha agents. So in her case, if this was failing, our next option was tocilizumab.
Any experience with pharmacogenetics, like if you now the Medgenome and all have got commercially available packs which will tell you whether they respond to adalimumab and all before you starting? So
we don't do genetic thing for the drug per se, but what we are also looking at, if there is a genetic autoinflammatory angle with the genetic analysis. So we've had patients with sarcoid-associated uveitis who have failed multiple drugs, including adalimumab and infliximab, even anakinra for that matter, in the same patient. And every clinical phenotype fits into that. So these are patients who are not isolated to the eye. They have multiple other parameters which are going on. The fever doesn't settle down. So I feel in this group we have kind of there has been a difference in terms of genetic analysis, and they have been able to pick up that. So one of our patients with sarcoid-associated uveitis, when they did the genetic typing, they realized ripamycin was a better option. So they have been able to shift medications that way. But that is only in a refractory uveitis. But like conditions like Blau, they are very variable. The data which we have, they have never responded very well with adalimumab. Whereas if I look at the data from elsewhere, they say they do very well with adalimumab. So probably the genotyping, we are dealing with something else which is not working with this. But the interesting part is they all respond very well with steroids. So sometimes they need that small amount of steroid to go on till we have a better drug.
One more question, ma'am. So the indications to start on biologics, you said first line JIA, But when it comes to a child with bilateral intermediate uveitis and severe occult vasculitis like capillary leaking, so will you consider first-line biologics in those patients?
No, I think pediatric vasculitis, I am a novice still because I'm learning by the day. And this is one, I think, because we do not know what the cause is. And that is my primary problem, when you don't know what the cause is. And this is where we are stuck. But when you look at all patients with pediatric intermediate uveitis, like how we discussed earlier, are we actually dealing with a vasculitis, or is it just that the pathway, the barrier is broken, is what we have to look at. And the drugs which work very well on the blood vascular barrier is azathioprine. So I think my first choice will be steroid with azathioprine in these cases rather than a biologics first, unless I'm looking at Behçet's with other involvement like occlusive vasculitis, retinitis. And generally these patients, if you think it is Behçet's, 3 years or 4 years follow-up, you will realize that it is not Behçet's, because you would still see retinitis or something like that if it is active Behçet's. So that's why it's my reservation with intermediate uveitis. I'm still not very convinced that this is Behçet's. So probably it is something else where the blood vessel barrier is broken.
Can we move on to the case presentations? First case is